Hello everybody, this is Rusty and we're going to talk today about the ACLS algorithm for non-shockable cardiac arrest. Remember folks, it's BLS before ALS. High quality CPR is needed. Assess the patient for breathing and a pulse for no more than 10 seconds. If you can't find it in 10 seconds, start compressions. Expose the chest, position your hands. Lower 1/3 of the sternum between the nipple line, and then push straight down. So get your shoulders over top of that patient so you can push straight down. We need to push hard and fast. Hard is 2 inches on an adult, and fast is 100 to 120 compressions a minute. And allow for complete chest recoil. If you're pushing more than 2 compressions a second, you need to slow down because that's over 120 a minute. Your compression to ventilation ratio is 30 compressions to 2 ventilations. Make sure you have that good CE clamp and you're giving that breath over 1 second. And breathe and breathe. Remember, the pace you need to be going is to the beat of Staying Alive. If you don't know 70s disco, then find yourself a metronome on your gadget phone. There's all kinds of apps out there to keep pace for this 100 to 120 rate. I, staying alive, staying alive. Or if you're evil, it is but a dump, bump, bump. Another one bites the dust. So keep the pace so you're in between that 100 to 120 compressions a minute. When the AED gets there, put the pads on where the picture tells you, right upper chest and left side. And the 2 simple steps to running an AED is turn it on and follow the prompts. So remember, to maintain that high quality CPR, we need to switch our compressors every 2 minutes. However, for this, the AED says no shock advised, but they are still not breathing and they still do not have a pulse. So they are either in asystole or pulseless electrical activity. One fact that the American Heart Association stresses now is chest compression fraction. Our goal for chest compression fraction is at least 80% of the cardiac arrest, somebody is doing compressions. So remember to minimize those interruptions in compressions to less than 10 seconds. You can keep compressing while the defibrillator is charging. And then if you need to shock, you're just going to hover. When they say clear, there's no more put your hands in the air, stand back 20 feet. Hover 6 to 8 inches above the chest. So as soon as the shock's delivered, you get back on cardiac compressions. And those are how we can increase our chest compression fraction. All right, we've started our CPR. We've got our O2 hooked up to our BVM as we're giving breaths, and we've got our monitor or defibrillator in place. And we identify a shockable rhythm? No! So it's either asystole or PEA. If it's asystole and PEA, we go epi early. We go epi early. Get a IV access. Get IV access and go epi early. Yep, we're doing that high quality CPR, 30 compressions to 2 ventilations. We have identified our non-shockable rhythm, asystole or PEA. We've completed our initial ALS care, IV, O2, monitor. We go epi early. And now, what's the dose of epi? 1 milligram every 3 to 5 minutes for the duration of the code. So, they've done some thought process, and they're attempting to make these cardiac arrests into a NASCAR pit crew. So the range is 3 to 5 minutes. So hey, 4 is in between 3 to 5. So how about epi 1 milligram every 4 minutes? Because then every other time we change compressors, we're giving a milligram of epinephrine. Man, that's crazy, but it makes sense. We're still doing CPR. Every 2 minutes we're switching our compressors, and 1 milligram every 4 minutes we're giving epinephrine. So then we're going to get some more work done. Let's get that advanced airway in place, because once we get that advanced airway in place, we can do continuous compressions. Continuous compressions will definitely get our chest compression fraction above 80%. And when we breathe, we just give 1 breath every 6 seconds. Let's slap that continuous waveform capnography in place so we can monitor our quality of compressions. Because in reality, good CPR in a person that may be able to survive has an end tidal between 10 and 20. So if it's below 10, you're going to try to improve that quality of CPR. So get the airway early, advanced airway early, so we can do continuous compressions in 1 breath every 6 seconds. Man, did I say advanced airway early? Yes. So we can do continuous compressions with 1 breath every 6 seconds to increase that chest compression fraction. We're doing CPR. We're giving epinephrine 1 milligram every 4 minutes. And we're switching compressors every 2 minutes. And now we've got to rule out those reversible causes. Hypoxia, we're doing the H's. Hydronion, slap the cap, monitor it. Hypothermia, get some blankets underneath and on top of our patients. And we lose most heat through our head. So hey, keep their heads warm, folks. I know you can probably think of a cardiac arrest that nobody had a beanie on, but they should be there. Then, of course, we've got this IV access to give our medicines, so give them some fluid boluses with this. And then we're going to look, if it's a PEA, we might be able to see hypo and hyperkalemia. If they've got that hyperkalemia, that's a lot of potassium swimming around the vessels. So hey, you might think about 1 milliequivalent of bicarb per kilo to help shove that potassium back in that body. So there's your H's: hypoxia, hydronions, hypothermia, hypovolemia, and hyper and hypokalemia. And here's our T's for our reversible causes. So we got 2 in the heart, 2 in the lungs, and then toxins. So the 2 in the heart are cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumothorax, and toxins. So remember those. 2 in the heart, cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumothorax, and toxins. Rule those out and treat them for those reversible causes of cardiac arrest. And here's the whole non-shockable side of the cardiac arrest algorithm. Go epi early. CPR, IV IO access, 1 milligram every 4 minutes for the duration of the code. Get that advanced airway so we can do continuous compressions and give 1 breath every 6 seconds, and slap that continuous waveform capnography. Remember, switch compressors every 2 minutes because high quality CPR makes you tired. So what's the sequence look like, and when do we stop? Things that make you go, All right, and here's our non-shockable sequence. We start CPR. Go epi early, get some IV access, and give 1 milligram every 4 minutes. 2 minute mark, we're looking, hopefully we got that advanced airway in place. We're doing continuous compressions, and we're giving 1 breath every 6 seconds. And we are switching compressors at the 2 minute mark and looking for reversible causes. 4 minute mark, we're switching compressors, giving that 1 epinephrine, 1 milligram every 4 minutes. 6 minute marks, we're switching compressors. 8 minute mark, we're switching compressors and giving 1 milligram of epinephrine every 4 minutes. Still looking for those reversible causes. 10 minute mark, switching compressors. 12 minute mark, switching compressors and giving epi 1 milligram every 4 minutes. Then 14, switching compressors. 16, switching compressors and giving epi 1 milligram every 4 minutes. 18 minutes, we're switching compressors, and so on. So, and looking for those reversible causes: hypoxia, hydrogen ion, hypothermia, hypovolemia, hyper and hypokalemia, cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumothorax, and toxins. Ruling those out. So, but when do we stop if they are in asystole? When? Question mark. Stop or withhold resuscitative efforts if they have rigor mortis in place. If they're stiff as a board, you're not bringing them back. If they have a DNAR, it used to be a DNR, but now it's a DN, do not attempt resuscitation order. Or if there is something threatening your safety, you can't survive or help anybody if you're a patient too. Some other considerations to starting and stopping, or how long you do it. If it's an overdose, you might work them a little longer. If it's a hypothermic patient that's been submerged, the old saying is, you're not dead until you're warm and dead. So you're going to have to warm them up to pronounce them and stop. Or if you got a temporary return of spontaneous circulation, then you may consider to keep resuscitative efforts a little longer. In hospital considerations of when to stop are time of collapse to CPR, how long was it? Time of collapse to defibrillation if needed. How many comorbidities do they have? What was their pre-arrest state, stable, unstable? The initial arrest rhythm, what did they start at? V-fib, a pulseless V-tach, or they started out in asystole and PEA? And the response to resuscitation. Did the person lay there unresponsive for hours before somebody noticed? And then here, end tidal. Get that advanced airway, slap the continuous waveform capnography, and monitor that end tidal CO2. Remember that CO2 that's getting off gas from your body is like smoke from the body's fire and metabolism. If the fire is not producing any smoke, then the metabolism is not working. So you can consider stopping if their end tidal is less than 10 after 20 minutes of resuscitative efforts. Because, well, there's no metabolism, not much smoke, and I doubt they'll come back to life. But there's a lot of things to consider. It's just not 20 minutes and done. Take all of those factors into consideration before you stop. Remember, non-shockable arrests, they are in PEA or asystole. So you go epi early, 1 milligram every 4 minutes for the duration of the code. You get that advanced airway in place so you can do continuous compressions and 1 breath every 6 seconds. And you rule out those reversible causes: hypoxia, hydrogen ions, hypothermia, hypovolemia, hyper and hypokalemia, cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumo, or toxins. Rule those out and take care of those non-shockable arrests. Thank you, American Heart Association, for updating your emergency cardiac care every 5 years, and I hope you enjoyed the presentation. Have a great day.